Our next session is Survivorship Trailblazers. We've got our lovely survivor moderator, Stacy. Give a wave, Stacy. Thank you. Who will help share your questions toward the end of the session. Joining us today are two dynamic women who are dedicated to partnering with patients to provide integrated, compassionate, and expert care throughout their treatment. Dr. Courtney Campbell is the Medical Director of Cardio-Oncology at Baylor Scott and White Heart and Vascular Hospital. And Dr. Meghan Heberton is an assistant professor in the Department of Dermatology at UT Southwestern Medical Center and the Director of Oncodermatology at the Harold C. Simmons Comprehensive Cancer Center. You can read their full bios on the app. Let's give a big welcome to Meghan and Courtney.
All right. So thank you all for coming. This is such a pleasure to be able to speak to patients directly and not just in a clinic setting. So for a brief overview of our agenda, I'm going to have an introduction on survivorship and then talk about cardio-oncology and lung cancer survivorship in particular, and then hand it over to Dr. Heberton, who'll be talking about oncodermatology and survivorship. And then the last 20 minutes we'll be opening it up to the panel for questions. Right? So. Part of the reason we're here is that anti-cancer therapies have dramatically improved the survival for patients with cancer. There are now over 18 million cancer survivors, and this is projected to keep increasing by 2035, over 22 million. And there's almost 700,000 people living with metastatic cancer. And what I've seen change since the beginning of my training was we were often taught that metastatic cancer was maybe weeks or days, months to live. And now it's something that people are living years with, and how to live with that is an important part, and part of why cardio-oncology itself exists is because suddenly other things besides the lung cancer come to be issues that we need to address. Over 70% of survivors have lived 5 years since diagnosis, and almost 50% have lived 10 years since diagnosis. So a large part of my practice are patients living with their cancer for years and how we navigate that. In particular, this is looking at individuals living with metastatic cancer, and you can see here in the orange box that is lung cancer. So almost 200,000 are living with either recurrent metastatic disease or de novo disease. And how, again, we navigate that's really important. And part of the reason we have so many survivors is there's been such an explosion of anti-cancer therapies, over 120 different drugs. And what I use in all my talks is actually a map of non-small cell lung cancer. And you can see in the early 2000s, we had one targeted therapy, a couple of chemotherapies that we used. And really since 2015, this has exploded. There are a lot of different targeted therapies so we can get really individualized based on cancer types, and a lot of immunotherapies as well, using the immune system, harnessing that to attack the cancer. And so the large range, there's different therapy lines that we can give, there's more and more, and people are living longer with all of these advances. All right. So, however, once with all these anti-cancer therapies, they can have in particular cardiotoxicities, which is the focus of my practice in cardio-oncology. All right. So this is just a broad overview of the categories of treatments and how I think about them. There's only a couple of chemotherapy types that actually will affect the heart long term. Many of what we deal with are targeted molecular therapy. There's a broad range of something called TKIs, tyrosine kinase, that have very specific molecular targets, and each of those can affect the heart sometimes in unique ways. And a lot of these are so new that we're still learning what those are. There's proteasome inhibitors, the immune checkpoint inhibitors as well. Hormonal therapies are not used as much in lung cancer. And then cellular therapies. A lot of these are directed now towards blood cancers, but with especially the CAR T, this is an avenue that the indications are broadly increasing. And then lastly, of course, radiation therapy, which is often used in lung cancer. And the radiation can be near the heart, and sometimes we do see side effects from that. So I'm going to just highlight a few of those particular treatments and how they delve into cardio-oncology. So a lot of times, like I said, we are sometimes surprised about the side effects that we see related to the heart, and that's because cardiovascular events trail the expected population rates in the pivotal trials for FDA approval. So we see a lot less atrial fibrillation, a heart rhythm issue, than we would expect in a similar population. We see less strokes, less heart failure, less heart attacks. And some of that may be just the population that's picked for clinical trials tend to be healthier. They try to avoid people that have any heart issues. But when you get that in a broader population, some of these will pop up as being signals that we might not have known before. And so with cardio-oncology, a lot of what we do, as a small community of us across the country, is try to identify these early so we can help these patients. And you see on the bar graph there that in non-cardio-oncology or non-cancer trials, the number of events is 1,400, but for cardiovascular events, it's down to 500, so just 1/3 of what's expected in broader trials. So for specific treatments, one of these is anti-VEGF treatments. These are things like Avastin, which can be a mainstay, also known as bevacizumab, axitinib. There's lots of different medicines along these lines. VEGF stands for vascular endothelial growth factor. And what these do is they really stop the blood vessels from going to the new tumor. And cut that off. And part of the side effect of that is increasing blood pressure because the endothelium, the lining of the blood vessels that are targeted, are really crucial to managing blood pressure. And understanding that these are a cause of high blood pressure is really important, especially when people are starting on these treatments. And it depends on the type. For bevacizumab, it can take 2 to 4 months to see the blood pressure increases. And sometimes they come to me because the oncologist wasn't able to give the treatment because their blood pressure was too high. And part of my job is I get people in quickly so we can manage that and keep them on their treatment. Other ones in this category, that rapid blood pressure increase can be within 1 to 2 weeks of starting. And I'm checking with people every week while we're potentially adding medicines to handle this side effect. And these are all things that are very manageable and not a reason to stop, but a reason to get an expert involved so we don't delay the treatment that we know can be very effective. Another common reason people see me is for the drug osimertinib or Tagrisso. Tagrisso has been fantastic for improving outcomes in lung cancer. It is a step above medicine like erlotinib. The effects of Tagrisso or osimertinib are not through the whole category of this particular medication or this type, the EGFR blockers, but specific to this drug itself. So some of the side effects we see from that are QT prolongation. So a lot of times when you're on this, they're going to be checking an EKG before you start and after you start a few weeks later to look at a QT interval. What the QT interval is on the EKG is you have a signal. The small bump there is the P wave or the top of the heart squeezing. The large up and down on there is what we call a QRS complex. It's the ventricle contracting. This is an electrical signal, and then it has to reset, and that's the T wave. What a lot of drugs that we use in cancer therapy can do is it can slow down the resetting process. And if it slows it down too much, by the time the next heartbeat starts, you can get into a dangerous heart rhythm. So that is something we monitor. And there are ways that we can adjust other medicines so we don't get into a dangerous long interval that causes the bad heart rhythms. A lot of the anti-nausea medicines can also prolong that interval, and so you can get additive effects. And so there's ways working together with oncologists that we can make sure it's safe. Some people naturally have longer intervals than others. If you're not someone with a low interval, we don't worry about it too much. Other things we see, there's a twofold higher risk of cardiac failure, so the heart getting weaker. This is something we tend to screen for every 3 months in the first year with ultrasounds of the heart. The goal is to catch it early before there's actually symptoms of heart failure, when we can use medicines to help keep the heart strong and prevent clinical heart failure. What I love about cardiology is that we have so many things we can do to address issues. We can find them early before they start causing symptoms and keep them from actually affecting someone's day-to-day life. The last thing we do see is a twofold higher increase of an arrhythmia, abnormal heart rhythm called atrial fibrillation, where the top part is shaking instead of squeezing. So it can be hard to know if the faster heart rate that you're feeling is an arrhythmia or just related to maybe not eating and drinking well that day. And these are, again, things that we can manage when we catch them. Another way that we see it, what I've seen more recently, is a medicine called loratinib or Lorbrena. This can dramatically increase someone's cholesterol levels. These are just two case examples that show it. In A, we see someone that was on alectinib before and transitioned to loratinib. They were on a statin and ezetimibe, 2 pills that we use. Their cholesterol was controlled, the total cholesterol around the 160s, and you can see that jump dramatically to over 300 within a few weeks of starting this medicine. This is not something that we want people to have cholesterol levels in the 300s or 400s I've seen uncontrolled for months or years on end. That absolutely increases the risk of heart attack. And so a lot of times what we're using are what are called PCSK9 inhibitors. These are actually injections that we use to help lower the cholesterol. It blocks a completely different pathway than the statins, and we can get that cholesterol level down quite dramatically and mitigate that effect of incredibly high cholesterol levels. In B, you see someone who was initially started on a statin when that cholesterol level went up, had a really modest effect, and then when they used the PCSK9 inhibitor, dropped it dramatically down. And these are medicines that really in the cardiology world, I think are slowly getting used more broadly, the PCSK9 inhibitors, but probably really only the last 3, 4, 5 years have been used in clinical practice more consistently. A lot of people don't know we have more than just the statin medications for cholesterol. All right, the next is our immune checkpoint inhibitors. These are medicines like Ipi/Nivo, nivolumab. And what these do is they take the brakes off the immune system, so the immune system will attack the cancer. And this has just been a huge change in how people are doing and living. I take care of patients that were told they had 6 months to live when they started these trials, and they're here 8 years later. And the metastatic disease just melted away because the immune system was able to target it. These are fantastic medicines. Now, over 50% of patients with cancer meet a category to potentially be on these medicines. So it's something that's being used broadly across different cancer treatments or cancer subtypes. What we worry about in cardio-oncology is the cardiotoxicity. Very rare events, usually within 1 or 2 doses, is where the immune system goes beyond attacking the cancer and attacks the heart. And so with this, it causes a myocarditis or pericarditis. That's inflammation of the muscle. And if that's not treated, that can be deadly. So we do a lot on focusing on identifying that early. The late events that we see and are important to keep an eye on is we do see higher rates of the heart getting weaker, high blood pressure, and progressive atherosclerosis. What that is cholesterol buildup. So I always, when I see patients on these medicines, check their cholesterol level. A lot of times, if the only physician you're seeing is your oncologist, something like your annual cholesterol lab probably hasn't been drawn. And knowing where you're at, looking at CT scans to see if there's evidence of some cholesterol buildup already in the heart is really important to make sure those risk factors are controlled, because folks that have been on these medicines are 3 times higher risk of a heart attack at 3 years compared to those that are not. And so it's not something that we can forget about cholesterol level. I'm dealing with cancer, because we don't want to add a heart attack on top of everything that's going on. So again, these are fantastic medicines, very rare side effects for the inflammation, but the atherosclerosis is something that we do see and I try to be very aggressive about controlling. All right, and this is a graph that's showing, looking at patients with lung cancer and known coronary artery disease. And what we see is that within 2 years of radiation, 1 in 10 had a major adverse cardiac event. And then within 5 years of radiation, 1 in 5 had a major adverse cardiac event. And that can be a heart attack or a stroke or a bad heart rhythm that put them in the hospital. We don't know exactly the mechanisms behind it. It's an area of active research. We have clinical trials going in the cardio-oncology world. But what I think this really reflects is that lung cancer and cardiac disease, particularly coronary artery disease, often go hand in hand. There are often shared risk factors, and not forgetting or putting the heart on the back burner, putting those cardiovascular risk factors on the back burner so we can recognize and mitigate the risk. All right, so the potential cardiovascular complications of cancer therapy are really broad. It can be cholesterol buildup or atherosclerosis. It can be a heart attack, myocardial infarction, cardiomyopathy, where the heart gets weaker, high blood pressure, hypertension, a stroke, and then abnormal heart rhythms, arrhythmias. But again, in cardiology, I love because these are all things we can manage. We can recognize them, we can treat them. You have a blockage in a blood vessel, we can control the cholesterol levels. We can put a stent in to open it up and help the blood flow. I think one of the things I do see is not all cancer treatments affect the heart. And sometimes I see anchoring, where someone goes, oh, they've got lung cancer, they're on cancer treatment, their heart isn't doing so well, it must be the cancer treatment, we should stop it. Sometimes and that was one of the first patients I saw when I started at Baylor. And what it turned out, though, is that patient just had run-of-the-mill coronary artery disease. We were able to go in, put a stent, open it up, and the heart started doing a lot better. The patient started feeling a lot better. The fatigue, not able to walk far without getting short of breath or chest tightness, maybe it can be related to the cancer, but sometimes those are all symptoms of coronary artery disease or angina, and that should be addressed and separate. And so not anchoring on one of those. So absolutely, some of the cancer treatments can affect the heart, but heart disease is incredibly common in our population, and not forgetting about that is really important from my perspective in the cardio-oncology field. All right, and so this is a graph that shows fatal heart disease among cancer patients by subtype. What I've highlighted there is lung cancer. So within the first year, there's actually a very high risk of cardiovascular disease and cardiovascular death. And then even beyond that, in the orange, gray, and yellow, you see 3- and 4-fold higher risk than the rest of the population. And so mostly I show this just to emphasize having a cardiologist involved, making sure your cardiovascular risk factors are controlled. Knowing what's underlying is really important for not just getting through your cancer treatment and survivorship, but living a healthy life without cardiovascular issues popping up. So as a cardio-oncologist, my job is to care for patients with cancer and cardiovascular disease, or just the risk of it. A lot of times people are coming to me, they're sent by their oncologist because the question is, can we give this cancer treatment, or is it safe to keep giving it after they had a heart rhythm event? And most of the time it's almost always yes, but let's watch closely so we can make sure they don't end up in the hospital again. So the main goals is to address the complications of the cancer therapy before, during, and after. Really to maximize the treatment and minimize the disruptions. There are ways we control that abnormal heart rhythm so it's not an issue while you're undergoing the chemotherapy that can trigger it. And ultimately it's to prove long-term outcomes for patients with cancer and cardiovascular disease. All right, so this is just an outline of what I see at different stages. So first, preventative. Has a cardiovascular risk assessment been done? Has anyone checked a cholesterol level, managed the blood pressure? It's really easy to say the blood pressure is a little high in an oncology visit. You know, emotions are high, it's stressful, you don't know what's gonna happen next, you're gonna get a treatment that you know you're not gonna like. And so high blood pressures can sometimes be brushed off when they might be underlying high blood pressure that needs to be addressed. And then it's a risk assessment. What treatments are being planned? What side effects are we expecting? Sometimes it's not adding blood pressure medicine, but we know that eating and drinking might be difficult on this. The nausea might be high. And with that, you probably don't need all the blood pressure medicine you're already on, and what to take away and how. And then what kind of imaging do we need at what frequency? Do we need to get an EKG every month or an echo every 3 months? And then we're there when something happens. If there is a heart attack, how do we get someone back on their treatment after they've had a stent placed, or they have a bad heart rhythm? How do we control that to get them back on treatment? And then especially in the survivorship, it is, do we need to keep monitoring? What are we looking for? A lot of my survivors I'm seeing on an annual basis to check in and make sure we're controlling those risk factors. All right, and then ultimately we are patient advocates, trying to bridge between the oncologist and the cardiologist. So patients with known CVD, cardiovascular disease, may be candidates for first-line cancer treatment. I've seen patients where they've done an echo, looked at their heart function, and it was reduced, squeezing 40% instead of 60%. And sometimes if your heart's not squeezing strong enough, you won't be a candidate for the cancer treatment they're planning. But we have medicines that can help with that. And a lot of times with those and a little bit of time, we can get the heart strong enough to take on those treatments that are recommended. And then conversely, patients with cancer may be candidates for first-line cardiovascular therapy. And a lot of this, it's only been 10 years for a lot of these medicines and this change. And a lot of cardiologists have been practicing for 20, 30, 40 years and aren't aware of all these changes. And one example is metastatic cancer has severe aortic stenosis. They need a new valve. When people were training, someone with metastatic disease wouldn't be a candidate because their prognosis would be less than a year. But now we know people are living years with metastatic disease, and they would be a candidate for, oftentimes we do transcatheter, so not an open heart surgery, but something through the leg where we're able to put a valve in and replace that aortic valve. And so a lot of what I do is make sure that the interventionalist doing the procedure or the surgeon doing the procedure and the oncologist understand how different things have changed, how different the treatments are in the last 20, 30 years. You know, in the 2000s, someone with metastatic cancer, our only option was open heart surgery, and that wouldn't be something we could do. Now we know metastatic disease is something people live with. It can be a chronic disease, and we have non-open heart ways to fix the heart valve. And making sure people get that, make sure that they live a longer, healthier life. So at our cardio-oncology center, it works a lot different than a general cardiologist because we're trying to get people in within 1 to 2 weeks. If the question is, should I continue my cancer treatment, you can't wait 3 months for the next available. You need to be seen as soon as possible, and we keep those urgent spots available. We develop a cardio-oncology monitoring plan and baseline risk assessment, manage the known cardiovascular disease. What do you do with blood thinners if your blood counts might drop on the treatment? What do you do with blood pressure medicines? And then figure out the right type of treatment for monitor. What kind of monitoring do we need? It's not, some folks are like, oh, I just do an image of their heart every couple months. And that's oftentimes not the case depending upon the specific treatments. And then we do participate in clinical trials across the country so we can find the best ways to manage this. And we do have a nurse navigator that helps with those appointments, which is a lot of times a lot easier than calling a general scheduling line. With that, I want to direct you guys to Cardio Smart. This is a publication of the American College of Cardiology. I help edit the cardio-oncology section, or the cancer treatment in your heart, and it's all patient-facing. It has some great infographics, as well as you can go to specific cancer treatments and see what do you expect when it comes to heart potential side effects. And and the last thing for empowering is Life's Essential 8. This is from the American Heart Association. These are 8 things you can do for overall improved cardiovascular health and quality of life, which is good nutrition, managing weight, good activity levels, good levels of cholesterol, blood pressure, blood sugar, not smoking, getting good sleep. And the one I want to emphasize is being more active. We know that patients that are more active during their treatment have a better quality of life and they live longer. And giving yourself grace if you have cancer treatment, knowing you're not going to feel well for a couple days, but when you do feel better, trying to walk that 30 minutes a day, walk at a level you can't easily have a conversation. If it's spread out 10 minutes 3 times a day, that's just fine, but all of that will help you feel better and have a better quality of life. And with that, I'm going to say thank you for listening to my part of this and hand it over to Dr. Heberton.
Thank you so much. I learned a lot. That was awesome. So I'm Meghan Heberton. I'm a oncodermatologist at UT Southwestern. Let me just see if I can, there we go. Okay, so I'm going to talk to you today about oncodermatology. I'm not sure if many of you are familiar with oncodermatology, but I want to kind of introduce the concept so that you are aware if somebody like me could be very helpful in your care. So what is oncodermatology? Well, we define ourselves as a supportive service to manage the cutaneous concerns of patients that are living with cancer. So I am not an oncologist. I'm a dermatologist, and I've always had a special interest in medical dermatology. I call myself a confused dermatologist because I was actually an internist before I decided to do dermatology. So I always had a very, very medical perspective on my field, but I truly think it's the greatest. Extremely biased, I'll admit it. But I absolutely love taking care of patients who are struggling with cancer drug and therapy toxicities. We consider ourselves a champion for you. We want to help because a lot of times dermatology is a very unique expertise. Most patients or most practitioners in their medical training don't get any dermatology experience whatsoever. And I can attest to this because, like I said, I was an internist. I knew absolutely nothing about dermatology until I did the specific training in it. And so we have a unique expertise, and trying to get to somebody who can immediately look at what you have and say, oh, yeah, I know what that is, and I know why you have it, is really empowering for people. So a lot of what we do is therapy toxicities. There are some other things on this list that may or may not be relevant to you as someone living with lung cancer. But toxicities is really what put oncodermatology on the map. We're lucky to have me at UT Southwestern, but there's also a few of my colleagues that do this, and if you're outside of Dallas, usually any academic medical center nowadays will have somebody like me on their staff. So how does dermatology relate specifically to survivorship? Well, many cancer therapies can create long-lasting skin side effects, including rashes, and having someone who recognizes that rash and can treat it can improve your quality of life. Similar to what Dr. Campbell was talking about, immunosuppression, prior radiation, and some cancer treatments can also directly lead to an increased rate of skin cancer. Skin cancer is still the most common type of cancer, and these are often not life-threatening, but it's something to kind of check off the list, and if you're at an increased risk of that, seeing any sort of dermatologist is going to help improve your health prevention. And then I would just say overall health, skin health, that's critical to survivorship. A lot of times I just get patients who want to talk to me about their quality of life because the skin is something that we all see. And if we can manage those symptoms, then we can improve our quality of life. So first I'm just going to talk about patients who are undergoing active treatment and some of the things that I can see and take care of. So I'm going to sound like a broken record today, but it turns out that sun protection is actually quite critical. And dermatologists are a big believer in sun protection. It's something we talk about to all of our patients. We also can help treat inflammatory rashes that come up on therapy. And what you'll find is if you talk to a lot of physicians, rash is just sort of a diagnosis, but to me, that's like a textbook, right? And there are lots of different rashes that can happen. And if you can find somebody that has expertise in defining what that rash is, then you can get sort of a unique, personalized treatment that can actually cure that rash. So that's something that we aim to do. And then I would just encourage you to consider an academic center or somewhere with an oncodermatologist if you are on unique therapy plans like Tagrisso, amivantamab, or Keytruda, if you develop skin changes associated with that, because like I said, it's a very unique expertise. Now, I'm really passionate about access to care, and so I do give a lot of talks to my dermatology colleagues in the community, because I recognize that I cannot be the dermatologist for everybody that is undergoing lung cancer treatment or on these therapies, and so there's a huge push within my field right now to help empower others that aren't in settings like what I am in or what Dr. Campbell does to recognize and treat some of these things so that patients can all have improvement of their quality of life and not necessarily need to be living somewhere like in Dallas, Texas. So what can happen to patients when they're taking an EGFR inhibitor? Well, EGFR inhibitors are a targeted medication. They're not classic cytotoxic chemotherapy. They are targeting a way that the cancer has learned to to develop and thrive against it. So that means that when I have a patient on an EGFR inhibitor, if they have a severe side effect, if I advise that we turn down the dose of the EGFR inhibitor, we should have an improvement in that side effect. It's a very dose-dependent mechanism. So hair changes can happen, nail changes, and there's all sorts of different rashes. I'll show you a list here in a minute that can happen on Tagrisso and amivantamab. I will say these often require intervention, and in sort of an exciting way, this is an area where there's a lot of research and trials. I'll show you some data in a little bit, but where companies are actually recognizing that if we can mitigate some of these side effects from the get-go, patients are able to tolerate these medicines better, and their quality of life improves. So it's really an interesting area of development. And there's actually some regimens where before you even start these medicines, you should be on other medicines to help control the skin side effects. So that's something you should feel empowered to talk to your oncologist about. I also consider myself a strong advocate for patients because some of these drugs in this category can cause just really tough things. I mean, these are things that are tough to endure, and I don't know if you were in Dr. Camage's lecture, you heard him talk about his own experience with amivantamab, and that not being the case for everybody, but sometimes I see things where I feel like I need to advocate on the patient's behalf to, you know what, we need to take a break. Let's give them a little bit of a break, and that is okay. We're going to be okay because this is not okay for this patient's quality of life, what we're doing with this drug right now. And we can get them back on a little bit, but it's okay to take a break. And so I really consider my role as critical in that regard. Sometimes the things that happen to your skin when you're on these medications affects a very small body surface area. So maybe it's in your mouth, or maybe it's in an area where you don't feel comfortable talking to your doctor about, or it's an area that's not examined often. So that's something that still needs to be considered. Just because it's a small body surface area, sometimes the smallest body surface areas have the highest impact, right? And so quality of life and severity are really important in considering how we adjust these medications. So this is just a list of some of the things that I see, and it's worth bearing in mind that not everybody gets all of these, right? But different things happen at different times, and maybe somebody who never had something at the beginning, 3 months in, develops something. And what I find is that the longer the patient has been on the therapy, the less likely the oncologist is to believe that it's related to that medication. But I definitely take care of a lot of patients who have been on something like Tagrisso for 3 years, and then all of a sudden something happens. And it takes them a while to figure out what's going on, but it's something that if you're in my field, we can look at and say, oh yes, I know what this is, I can help you with this. So that's really refreshing to patients. So what can you do? Well, if you don't get these things, that's good. Just don't worry about it. Things that you can do to prevent: regular use of a moisturizer, because a lot of these medications challenge your skin barrier and how your body's ability to retain moisture. What my patients tell me is, like, I am just bathing in Eucerin and it looks like I have nothing on. And I believe them, right? But it still helps to try and prevent these things. Avoid sunburns. All of these medications make you more sun sensitive, so if we can avoid sunburns, that's gonna help. I usually have my patients with EGFR inhibitors use a HiPA wash, which is just something over the counter, neck down in the shower 2 to 3 times a week, because the longer you're on an EGFR inhibitor, the more likely you're to develop an infection. That's not because you're doing anything wrong. The EGFR inhibitor just kind of changes your body's own microbiome and your ability to kind of fight off these skin infections that are everywhere around us. So a HiPA wash can really help. Just a gentle cleanser to face. We live in the TikTok era. There's a lot of skinfluencers out there, and I mean no disrespect to them, but I do sometimes find it challenging where people are looking for advice and they'll come to me and they'll say, well, these are the things that I'm using, and it's like several shoe boxes worth of things, but really simpler is often better, okay? Just a gentle cleanser is all you really need to your face. And then really talk to your doctor, be your own advocate. If skin changes develop, there are things that we can do about this, and it's worth bringing attention to it early before something advances. This is one of an example of the preventive work that's going on out there, where we have, for amivantamab specifically, something called the Cocoon trial. And I'm really excited about this because I feel like it's my field getting attention to as to the impact that dermatologic intervention can have. And so Johnson & Johnson looked at whether if we had preventive or prophylactic dermatologic intervention in patients, were they able to mitigate side effects? And the answer was yes. Patients had a reduction in grade 2 or higher adverse events at week 12 in the intervention group. So we have emerging data that early interface with the dermatologist for some of these drugs, which reliably cause skin side effects, helps. Dr. Campbell did a really excellent description of immune checkpoint inhibitors. I will just point out that the skin is actually the most common place where we see side effects from immune checkpoint inhibitors. This is really hard for oncologists to counsel on because essentially you're counseling on a drug which can save your life, remarkably prolongs life, has completely changed outcomes. But in terms of the side effects, basically anything is possible. And so I often run into patients where they're like, well, nobody ever told me that this could happen to me. And sometimes it's because we didn't know that it could happen, right? But these therapies really have changed cancer outcomes. What I will point out with immune checkpoint inhibitors like nivolumab, pembrolizumab, is that the timeline is out the window when we think about drug reactions developing. So if you have a penicillin allergy and I give you penicillin, about a week later you're going to get a rash, right? If I give you Keytruda and you have some sort of checkpoint inhibitor toxicity, I can give you a vague idea based on the type of rash, like when that might occur, but the timeline is out the window. I see people that a week ago started it and have a diagnosis. I see people that a year ago started it, and then now all of a sudden there's something that comes up, and I can say that that's from their checkpoint inhibitor. So that's why it really helps to have an expert evaluating whether it's related or not. Similar to Dr. Campbell, one joyful thing that I love to do is say, oh, this has nothing to do with your cancer or your cancer therapy. I can give you an antifungal cream and this is going to go away for 2 weeks. So don't worry, not everything that happens is going to be related to these medications. And then, you know, when I lecture oncologists, like I said, in medical school, we don't get a lot of dermatology. So, you know, in all these trials, when you read them, what's going to say is that the patient experienced rash. But as I alluded to before, to me, that's hundreds of different diagnoses. That's a whole textbook, right? So it really helps to see exactly what the rash is. If you have psoriasis, I'm going to treat that a whole lot different than I'm going to treat something like eczema. I'm going to treat that a lot different than if you have granuloma annulare or hives. And so there are specific treatments and interventions that are dedicated to each one of these diagnoses. So I'm off therapy. What do I do now? Well, in terms of long-term dermatologic considerations, what we always recommend, because a lot of people are worried about a lot of the spots that they have, but if something's rapidly changing, if it's tender or if it's something that bleeds easily, you should get that checked out. Those are all kind of warning signs. Just as an optimism, most skin side effects from prior treatments are going to go away on their own, whether I help you or not. Because once you finish therapy, a lot of these things are dose dependent, like I said, and then things should calm back down. The exception to that is immune checkpoint inhibitor rashes. I have some patients that are still seeing me years later, and they haven't seen their oncologist but once a year. They're still coming to see me every 3 months. So, you know, these things are a little bit unpredictable in that regard, but most things like Tagrisso, amivantamab, you stop the medicine, your skin may be a little more dry than it was before, but you're not going to have the sort of side effects that you were experiencing while you were on treatment. And then I'm just going to do what they say, like the no gatekeeping. I'm going to try and give you some advice on the things that I get asked about all the time, just so that you have that information as well. So what kind of sunscreen should I use? I told you sunscreen's so important, and that all dermatologists believe in it. And I feel like sunscreen's gotten a lot of hate recently on social media, and there's all sorts of concerns about it. But generally, we do know that sunscreen helps prevent skin cancer. Sunscreen is not regulated by the FDA, so there are all sorts of direct-to-consumer marketing, and what you'll find is that dermatologists tend to recommend sunscreens that are marketed more closely to them. What, in general, we think is the safest option for sunscreens are zinc or titanium sunscreens, because those are physical blockers. They shouldn't be absorbed by your body. Sunscreens come as either chemical or physical, and most of the concern, which we could have a debate about the scientific basis for a lot of the concern, but If you're concerned about using sunscreens, most of that concern relates to chemical sunscreens. And so zinc or titanium is generally considered very safe, but they also tend to be very white and pasty. That's why they work so well. So I recommend tinted options. So if you have an option that says it's a tinted mineral sunscreen, that's going to go on the nicest to your skin, look the least white. It will also work across all skin tones, which is super important, and also work to prevent sun damage. I cannot, if I had a penny every time somebody told me, well, I don't really go out that much, I don't get a lot of sun, I would be a very wealthy person, because everybody gets a lot of sun. We all get ambient UV, just going to the car, being even like walking across the mall here today. So I don't expect you to completely cover up all the time, but put some on your face every day. It's really going to help prevent sun damage and skin cancer. What are the best moisturizers? Well, there are many choices for these. Again, totally unregulated. It's all direct to consumer. What dermatologists tend to recommend is that a cream or an ointment tends to have less alcohol or water content, and that's going to be more moisturizing than any sort of lotion. So a general rule of thumb is if you're in the store and you see something that's in a jar, that's going to be more moisturizing than something that's in a pump bottle. Okay? And then what can I do over the counter for anti-aging products? Again, widely marketed. What actually has the best evidence is adapalene or Differin over the counter. That's the only direct available to consumer retinoid. Most things are retinols that say that they're anti-aging over the counter, and those are like a drop in the bucket in terms of strength. You're gonna find adapalene or Differin in the acne aisle, and just putting a pea-size amount on the face each night and using that over time is gonna have a cumulative benefit for fine lines, wrinkles, skin texture, and collagen buildup. We recommend applying that to your face at nighttime and then just continuing as long as you can. You may need to use a moisturizer because it does tend to be quite drying. And then sunscreen, like I said. So I just want to thank you for your trust and remind you that you are the reason that we do what we do every day. You are what inspire us to come to work every day and provide care and hope, and you provide us with hope and fulfillment. And it's such a partnership, it's such a privilege to be able to share this journey with you. And I truly hope that we can help you improve your quality of life and help you get through these things. This is a picture of my family, just proof dermatologists still go to the beach. But my 4-year-old knows that if he's gonna go outside to work on the yard, he's like, Mama, where is my hat? So I'm probably brainwashing him a little bit early, but it's okay to have fun. Go out there, go on your vacation. Just please wear a hat while you do it, okay? Thank you.
Thank you so much for all of that. I'm sure that many of us long-term survivors heard things that we have experienced or now have questions about. So I'm going to go ahead and read questions from the app. Even if you think you don't have a question, if you get in the app, if you read through those, you can give them an upvote so that we can get the most important or the things we're all dying to know. So go ahead and take a peek at that. So the first one is about cardiology. How do you get a cardiologist on your team if you don't have any known cardiovascular issues? Do you ask your PCP or your oncologist?
I would say either is a great option. If you're looking for someone that specifically has experience with the oncology side, I would recommend your oncologist. They know the cardiologists that are most familiar. There are more and more cardio-oncologists out there. Most of them are in major cities, but even a lot of my patients, they come down to Dallas for their trial and they might see me, but they have a local cardiologist as well that they can go to. So we work in conjunction, and I think however you can get one, that's important. And a lot of what we do is just baseline risk assessment and saying, you know, does your cancer treatment have an effect or not? And if it doesn't, that's fantastic. And you can go to your PCP with a game plan of, you know, how you can optimize your cardiovascular health.
Thanks. If you are on osimertinib or Tagrisso, and you're not getting regular EKGs, should you be asking your oncologist about it?
Sure. So I think a lot of that is done at the very beginning. So especially with the EKG changes, we expect those within a couple of treatments, a couple of months, and usually we don't do long-term screening after that. With the echocardiogram side, a lot of times we do that within the first year, and then we spread them out afterwards. I think if you haven't had one checked, I would definitely ask. And it's always okay to ask for a referral for cardiovascular questions as well.
Great, thank you. So for dermatology, is it recommended to get a baseline visit with an oncoderm if you are on an EGFR inhibitor?
That's a great question. I would love to do that. Volume tends to be the issue in terms of ratio of number of patients to oncodermatologist. What I would say is that most EGFR inhibitors are kind of the OG of oncodermatology. Like, they have been around and known to cause rashes and actually like made my specialty necessary because of the predictability with which they cause skin side effects. For that reason, oncologists are fairly familiar with the rashes, especially at the beginning, that EGFR inhibitors cause. It's also reliable in the type of rash, because, I talked about immune checkpoint inhibitors. There's so many different diagnoses that can happen. Asking somebody without training to do a diagnostic evaluation of a rash is really challenging. But with an EGFR inhibitor, especially at the beginning, that acneiform eruption, oncologists are familiar with that. And since we have fairly good data on prophylaxis, they're often able to manage that, and you may not need to see somebody like me. Now, if you have specific needs, you have a special like concerns about like your type of hair or that like for sure I'll do baseline visits for that. But oftentimes it's more reactive if something's not working based on the prophylaxis that we standardly do to see an oncodermatologist.
Great, thanks. Another question is, are oncoderm virtual visits available for people that don't live near someone?
Not yet, to my knowledge. One challenge in dermatology is we are such a visual field. And so a lot of the diagnostic evaluation is so important in person because we look, we touch, we evaluate. So I have several patients from the greater area that I really try to respect appointment fatigue and distance fatigue. But usually at least that first visit, I try to get a sense of, especially body surface areas that you can't really like examine in a virtual visit. And then after that, especially for some of the interventions we do on like Tagrisso with isotretinoin, I'll do virtual visits for follow-up.
Great, thanks. Another question about cardiotoxicity. I didn't see ROS1 on the list of mutations controlled by TKIs that increase cardiotoxicity. Do ROS1 TKIs cause cardiotoxicity?
They're not as common, I would say. It's not a big part of my practice for those specifically on the ROS1 inhibitors. It really is specific to the type of the particular target, and some of them we're still learning about. So, and sometimes it really is just drug interactions, and it's specific to the type of treatment. So, and these are all big categories of treatments. Off the top of my head, I can't think of any. It's not a big part of my practice, but a lot of it is also learning. It's very common that, at least once a day I'm getting on the clinical trial website because I have people that are, in phase 1 or phase 2 studies, and we're still learning what those side effects are. And so some that have been around, like Tagrisso, we're very familiar with, but some of the cardiotoxicity effects really weren't well known until 3 or 4 years ago. And then with other newer ones, we're looking, I want to say the RAS mutations, some of it is more just drug interactions with some of the statin medications. But it's all, it's joint with everyone on what their treatments are, what are their past treatments, and how that's interacting with their current active issues. And so there's multiple prongs for how we approach a specific patient and the specific issues that they have.
Great, thank you. Dr. Heberton, lots of people would like to know what skin cleanser and lotion for body and face do you recommend?
I'm brand agnostic. Okay, a lot of my patients like CeraVe gentle cleansers. I like Cetaphil. Again, all these people like market heavily to dermatologists. So if you like something and it's better for you, that's great. I have no connections with any of these companies. Even though it's in a bottle, I do like La Roche for moisturizing. Sometimes we reach on that like uncanny spectrum where it's like super moisturizing, like Vaseline, honestly, the best type of moisturizer you're gonna get. But who wants to wear Vaseline on their skin every day, right? Nobody like going out. And so if you're really, really dry, which can definitely happen on a lot of these medicines, put the Vaseline or the Aquaphor on at nighttime, or immediately after taking a lukewarm shower, coat yourself in a moisturizer. If you're extra struggling, wrap like a damp towel over your back at that moment. That's called a wet wrap, and that really maximizes the amount of moisturizing that you're doing. That's like what we do with our little kids who have eczema when we admit them, is we'll clean and then apply their medicine and their moisturizer and then put damp pajamas on them. And so I try to recreate that at home for some of my patients that are really having trouble with that moisture locking in.
That's great. Again, with the brand recommendations. But
Am I going to get in trouble if I?
No, I don't think so.
Is this being recorded?
So.
Okay.
Right. And I think people sometimes need to know where to start. And
I
yes,
understand.
it is being recorded. I know. But also a brand of zinc or titanium sunscreen.
Okay, yes.
Or maybe multiple.
Yes. So most sunscreen companies are getting sort of aware about like the need for good mineral options. And I think there's also been a lot more awareness lately about skin tones across all phototypes to try and get sunscreens that work across phototypes so that you don't have to have pale skin like mine to be able to wear sunscreen. I like Tizo, T-I-Z-O. They have a mineral-based pigmented sunscreen that will go nicely on a lot of different skin types. It's like an SPF 40. ELTA heavily markets to dermatologists. So again, I'm very aware that we're all biased, but I like them, but they're a little bit more expensive. That's going to be like a $50 sunscreen. Eucerin has a great like $10 to $15 option. That's good for the face. SPF 30 to 50 mineral-based pigmented option with it should look brown when it comes off, but it won't go in brown. It just makes it not look as white and pasty. So there's some examples across different price points. It should not be like something crazy expensive. I think a lot of that's really like false advertising, and it doesn't have to be from a dermatologist's office. Like I get my sunscreen off Amazon, or Walmart.
Thank you. And we're just about to finish up, but one last question, and that is my radiation oncologist able to determine how much radiation my heart got during my lung cancer radiation treatment a few years ago?
Sure. So with radiation oncologists, they do keep track of how much radiation the heart gets. That being said, we've appreciated a lot more that it has to do with the heart substructures. So we deal with it a lot in breast cancer. There's breathing techniques where you can use to get the heart out of the way depending upon where the radiation is being targeted, but still small parts of the heart can get relatively high radiation doses while the overall mean radiation dose to the heart is smaller. That being with all of that, with radiation, The side effects are generally long-term. So most of the patients that I'm seeing for radiation side effects, they had treatments in 2005, 2010, more than 10 to 15 years ago. And that the way we did radiation in that era was very different than now. In that era, we weren't really aware of long-term toxicity related to radiation with the heart. It was thought the heart is highly metabolic and doesn't have those effects. We've now seen that it can cause fibrosis or some scarring of the blood vessels that supply the heart and the heart valves themselves. It's a small percentage. I maybe see 1 or 2 patients a year that had that radiation related damage. And with radiation oncologists, their system is entirely separate from anything that the your general doctor is using. And so for me to try to ascertain exactly how much radiation was received, it's incredibly difficult, and it doesn't really change how I'm managing patients. So generally, if it's been 5 years or 10, if it's been 10 years since you've had radiation, it was somewhere in the vicinity of the heart, I'll screen and look for, is there signs of it? We do, most of the time we do an echocardiogram, which will look at the valves, how well the doors between the chambers of the heart are opening and closing. And then I'll do what's called a CT coronary angiogram. It's a CT scan timed with the heartbeat. Contrast lights up those blood vessels that supply the heart, and I can see if there's narrowing from the radiation. That's a lot easier than trying to say, well, you only got 5 grays, you got 30 grays, therefore I'm going to do this for you and that for you. It's hard, and ultimately the testing is fairly straightforward to screen for it, and not something we do every year. This is a process that takes 10 plus years down the line. And so if everything looks good at 10 years, maybe in another 10 years we'll just repeat it. And at 5 years we might do a stress test to see if there's any signs that blood flow is compromised. An echo is an easier thing, and we may do that every 5 years. So it's not an annual thing. And if there is radiation, I generally treat it. I don't focus on the exact amount something got, but I just look broadly for those effects.
Great. Thank you so much, both of you. I think we know that we've got lots of long-term issues, and being able to address them is great. So let's give them a round of applause. Thank you so much.